Otis kindly stepped in and took this spot. Dr. Corin will now be in May. I think I've taken a look at these slides already. This is a very interesting presentation, especially for American allergists who, in my estimation, have, compared to those in other parts of the world, taken up sublingual immunotherapy less, certainly to a lesser extent, and I think some of his data will share that. So Dr. Nolte, go ahead and get started, and thank you very much for filling in for us on just a couple of days' request on my part.
Well, thank you very much. And let me just make sure, can you see my screen and the slides starting with new developments in SLIT?
Yes, I do. See you.
All right, so thank you very much for the invite and good morning to everybody. I appreciate that you're logging on this early, and I know you probably have your coffee ready, and I'll try to speak you through the slides. I will go fairly quick, but I will have a few places where I will pause and then encourage you to ask questions. And by the way, I don't mind if you are interrupting, if there's anything you need me to clarify. Just briefly on my background, I'm a pulmonologist. I'm also trained as an allergist. I used to be professor of medicine at the University of Copenhagen, but I've worked in the industry for about 15 years, mostly on drug developments, Nasonex, Claritin, combination drugs, and then recently in 2005, I picked up the developments of sublingual immunotherapy tablets. And today I will share with you really some of the evidence-based AIT management strategies around allergic rhinitis and conjunctivitis treatment. I will review some of the new safety and efficacy outcomes we have from recent tablet trials, and I will share with you some quite interesting data because we have such large trials across the world indicating that we have, I would say, many similarities between the various tablets and how we use immunotherapy across regions and across age groups. And that's fairly new information, and I think that would be of interest to you. Basically, as you likely know, some of the major treatment goals for allergic rhinitis and conjunctivitis is really just to show symptom improvement. And we want to see patients are benefiting from the treatment, and that could be pharmacotherapy, it could be immunotherapy, by a reduction in rhinitis symptoms and conjunctivitis symptoms. Many patients have both symptom manifestations. Clearly, we have an interest in treating with long-term and persistent effects, and that means sustained treatment during therapy. Typically with pharmacotherapy, we will maintain treatment effects during the course of the treatment. However, one of the, I would say, upsides of immunotherapy is that there might be maintained treatment effects after discontinuation of therapy. We're looking for disease-modifying effects. Clinical trials, both with SCIT and sublingual immunotherapy, have indicated that this persistent treatment effect after discontinuation may at least work for at least 5 years or maybe even longer. The most recent clinical trials with sublingual immunotherapy have only evaluated the treatment effects for 2 years after discontinuation. Preventive effects, clearly the ultimate goal, and that is showing reduced risk of new allergen sensitizations, and also trying to see if we can reduce the risk of developing asthma. There are trials indicating that that might be the case, and I will share some data with you in one of the slides. The overall arching goal clearly is to minimize local adverse events. We'll see local adverse events both with pharmacotherapy, such as, for instance, dry mucosa in the nose with nasal steroids. There could be potential risk of nosebleeds. And for local adverse events, SCIT typically will give small bumps at the injection site. And for the sublingual immunotherapy, we will have local adverse events during the sublingual administration, typically oral itching. And we'll talk about this later. Clearly, the risk of systemic allergic reactions for the SCIT, where the data indicate there's a higher risk with SCIT versus sublingual immunotherapy. So why was sublingual immunotherapy actually developed? Really to try to see if we could increase the use of immunotherapy because there are some benefits compared to the pharmacotherapy. So when we just look at inhalant allergens affecting people in the United States. We have a population around 330 million, at least back in 2021. We know that about 30% of a random population is sensitized to inhalant allergens. That doesn't mean that they have clinical allergy, but they are sensitized. When we look at the patients who are actually suffering from symptoms, 10 to 40% have allergic rhinitis. And 13 to 14% of children and adults have a confirmed diagnosis of allergic rhinitis. When we look then at how many patients on average in the US is actually starting some kind of immunotherapy, it's only 1 to 3 million per year, and it's likely more towards 1 to 2 million. Out of those who have allergic rhinitis, 20 to 40% also have allergic asthma. So there's a significant comorbidity in allergic rhinitis, including asthma symptoms. And 80% of those patients with AA, so allergic asthma, have allergic rhinitis. So if you have asthma, you're highly likely to have allergic rhinitis. And clearly that if patients are suffering from these diseases, it can affect the overall quality of life. Specifically, patients will have flare-ups of asthma, they may have poor performance in school, they may have absence from work, etc. So we know what the economic and the social impacts are with this disease. So when we look at patients actually going through the journey up to getting more severe disease and where they typically will consult with an allergist, there's actually quite a long progression. For adults, it takes typically 10 to 15 years from the symptom begins and until the patient's actually getting into a disease stage where patients are motivated to start immunotherapy. In children, we see somewhat shorter, but on average, around 5 years before patients have significant disease motivating to consider allergic or allergy immunotherapy. Until then, patients will try all kinds of remedies. They typically also will have tried different kinds of over-the-counter medication, even nasal steroids, before they go to the allergist. So one of the concerns was with immunotherapy is that, well, if it's needed to come into the office bi-weekly, once a month, it may not be very convenient. And it was thought that maybe one of the reasons for the poor uptake of immunotherapy in general across the world was because of the inconvenience, but also perhaps the concern with safety. And for that reason, we took a look at the Timothy grass SLIT tablet. We looked at the injection therapy with Timothy grass, where both products were based on the same formulation. And when we look at the Timothy grass SLIT tablet pharmacovigilance data, you can see that the risk of anaphylactic shock was actually quite low. So based on 49 million exposures, there was one recording of an anaphylactic shock, which, by the way, was fairly easily to manage. It occurred at the first day of the tablet administration in the office, and the patient was treated with epinephrine. When we look at the Timothy grass immunotherapy, we can see that out of 0.5 million exposures, we had 21 cases of anaphylactic shock. So clearly this data suggests that the risk of anaphylactic shock is quite high compared to the SLIT tablets. With immunotherapy, injection therapy, there has been in the ALK portfolio a couple of deaths, one with CAP and one with house dust mite within the last 16 years. So there's clearly a risk with injection therapy that there could be near fatal or fatal reactions. That has not yet been observed with sublingual tablets. And that's one of the reasons why maybe one can consider to introduce immunotherapy earlier than until the very end, where patients are quite desperate, try to see if they can get better treatment effects than what they receive from pharmacotherapy. So when we look at the use of immunotherapy across the regions of the world, you can actually see there's quite a difference in the medical practice. When you look at Western Europe, about 40% of immunotherapy is related to injection therapy. 31% is actually tablets, and that has changed dramatically throughout the last year. So COVID actually had an impact of the use of immunotherapy. In Asia, where COVID was quite rampant and still is, 60% increase in tablet use. In Europe, it's been about 50% increase of tablet use, and unfortunately, on the expense of SCIT. In the United States, there was a 50% decrease during COVID in injection therapy, and there was about a 15% decrease in sublingual tablet use. But that has now reverted, so we see more injection use and also more tablet use. When you look at Eastern Europe, Russia, and Southeast Asia, you can see tablets are dominating the form of immunotherapy, 72%. For the US, it's quite the opposite. 85% of immunotherapy in the US is carried out using injection therapy, and only a minority are using tablets. For Canada, the reverse, 68%, and that's actually increasing now because of COVID, where there's been a quite dramatic increase. You can see much more use of tablets, and the same for Japan, where it's actually dominated by children, where about 67% of the patients getting immunotherapy are children, and that's because in Japan, there's no lower indication, no lower age indication for the tablets. So you can actually use tablets for house dust mite treatment in children below 5 years of age.
Dr. Nolte, can I ask you a question?
Sure.
In the US, to my knowledge, there isn't any drop therapy, any oral liquid product that's FDA approved. Is that different in other parts of the world? Are there legitimate sublingual drops? In this country, that has an image of a poor image, that there isn't any valid treatment of that kind.
It is true that there's no approved drug for liquid administration of immunotherapy in the US. And it's also true that there are physicians who are using bulk extracts for administering sublingual drops. And that has not been documented to be effective. There's a few products in Europe which are approved. However, the regulators in Europe now have asked companies who have been selling off-label or on a named patient basis these drops have to document by clinical trials that they are effective and safe. And if they cannot, they have to be removed from the market. ALK had a couple of products which were drop-based, and they were commercially available. They have been taken off the market because clinical trials didn't document efficacy. But there are still a few drop-based formulations, especially in France and Italy, which has been improved or where they are in the process of being documented. The companies have been asked to do it within 5 years. If they can't provide substantial evidence, they will be taken off the market. And that actually goes into the next discussion, and that is, so what is the evidence for these various products? Clearly, the drugs are going through rigorous FDA review based on clinical trials, but the SCIT extracts used in the US have really not been documented. Even though they are approved for use for injection, there are no clinical data to support it, and they have been grandfathered in. With the new immunotherapy products, they have to go through phase 1, 2, and 3 programs and have to be reviewed by the FDA before these products will be approved. And basically, the standard is randomized double-blind placebo-controlled trials, and that is something which is being endorsed by the various specialty organizations in the US and in Europe, and also clearly by regulatory agencies across the world. So it may surprise you, but if you look at well-powered randomized controlled trials supporting SCIT immunotherapy, we only have 2. One by Dr. Frew, conducted in the UK. It was a Timothy grass injection therapy product which was evaluated, and it clearly showed efficacy against allergic rhinitis and conjunctivitis. And then Dr. Debusky also did a study in the US with 1,000 patients, and that was also GRAS, and it showed efficacy. On the other hand, when you look at SLIT drops, there are 4 trials showing some efficacy. 2 of the trials actually came out negative, and 2 of the trials showed efficacy. One trial was the one by Creticus, where they used ragweed sublingual formulation. It was never approved by the FDA because the data actually indicated a fairly poor efficacy. When you look at the SLIT tablets, on the other hand, there are multiple studies, randomized, and all with very high numbers of patients. Some of the largest trials are typically including around 1,500 subjects. And most of those trials have showed efficacy. 2 trials have not shown efficacy, but the other ones have all showed efficacy. So when we look at treatment regimens for the various products, they can actually vary. So as you know, injection therapy is administered year-round. And typically patients will be treated for 3 to 5 years, although generally it's recommended only to treat for 3 years and then you stop the treatment. Sublingual treatments can be either pre and co-seasonal. There are also data suggesting that year-round dosing, for instance with Timothy grass, actually leads to disease-modifying effects. So that's the way it's typically practiced in Europe. If you use sublingual tablets, you use perennial treatment also for the pollens. In the US, pollens are typically treated pre and co, and for the house dust mite, it's treated year-round. When we look at the SLIT tablet trials, I'll just give you the general design. Patients, depending on where you are in the development cycle, can be included when they're typically from 5 years up to 65 years of age. They need to have a clinical history of the allergy, and it has to be documented by sensitization using skin prick test and serum ID to the allergen in question. Patients with a medical history of severe or unstable asthma are excluded. These patients are typically at risk of having more severe reactions if they have an adverse event. Primary endpoint is typically a combined score where patients will be recording symptoms and they will be recording their rescue medication, and then that's combined and evaluated. As you can see, you can use either pre and co-seasonal. So typically if it's a pre-seasonal, co-seasonal study, patients will initiate treatment 12 weeks prior to the pollen season. And then you treat them throughout the season and you evaluate. Some of the trials we have conducted, patients will be treated throughout the period of the year and also for a total of 3 years and followed for 2 years to assess if there is a disease modifying effect. For the perennial therapy, house dust mite, we use year-round dosing in all trials. Patients can also be co-administered SLIT tablets. That is not an approved formulation or approach in the US. It is not approved anywhere in the world, but on the other hand, physicians are actually experimenting with co-administration. And we have also conducted a couple of trials, one in Japan where we combined the treatment of cedar pollen with a cedar tablet along with a house dust mite tablet. Another trial here in North America included the evaluation of co-administration of grass and ragweed. The typical way of doing it is you initiate one tablet for 14 days, you pause in the morning the tablet you already took, and then you add the new tablet on to see if there's any side effects. And then you do morning and evening of each of the 2 species for 2 weeks, and then after 2 weeks, if tolerable, then you can co-administer within 5 minutes. And that hasn't shown a safety signal. Efficacy has not yet been evaluated with this type of treatment paradigm. So what are the tablets available in North America? There's a grass tablet. There's actually 2, one a 5-grass tablet, and then there's a Timothy grass tablet. They're both characterized by total potency, but also by allergen content. So typically these tablets contain around 15 to 20 micrograms of major allergen of Phleum P5. Then there's a house dust mite tablet called 12 standardized quality units. And typically, the tablet contains a total of 30 micrograms of the two species of major allergens. So that's Pityrianismus, and it's the Rhinitis species. If you look isolated at the two species, it's 15 micrograms of DIR1 and DIR2. And then there's a short ragweed. It contains 12 micrograms of the major allergen. And then you have the Burt's tree tablet, which is approved in Canada and Europe, but has not yet been evaluated in the US. And that one contains around 50 to 60 micrograms of major allergen of BITB1. It's only the grass tablet, which is approved down to the age of 5 in the US. The other tablets are only approved for adults. And just to give you a flavor of this, when these tablets are being formulated and characterized, we know the major allergen content, we know the total potency, and we also characterize the components. So on the on the right side of this slide, you can see a cross-radio immunoelectrophoresis pattern where the two dark bands shows the presence of DIR1 and DIR2, so the two major allergens. But in the back, you see more faint circles or areas, and those are the other allergens which are present in house dust mite. There's around 21 important allergens in house dust mite to which patients can become sensitized. All tablets are not made the same way. This picture shows the dissolution time of the Vitis formulation on the left, and you can see another compressed tablet on the right. Slow absorption on the right side and very quick absorption with the very first tablet on the left side. We think that's important because the way the allergen is being presented to the immune system is through passive absorption at the application site. So if you put the tablet under the tongue, there will be a small surface area driving a high kinetic profile. So small surface area, quick passive absorption, approaching the submucosa and then the dendritic cells. If you have a liquid formulation or a compressed tablet which slowly absorbs, there likely will be less passive absorption because the kinetics are spread over a big surface and slower. And actually some of the residue or the material would be swallowed and can cause lower gastrointestinal side effects. So the formulation, I think, is really important. And it's also important for pediatric use, because if you have a quick absorption of the tablet and it sticks to the mucosa, just like the Vitis formulation does, then children have less risk of aspiration and probably will have less gastrointestinal side effects because they don't swallow the material. So this is the way we measure symptoms for clinical trials. And I'll just give you as a preamble an understanding of this, because then I will quickly go through some of the results. Typically, we will measure 2 eye symptoms and 4 nasal symptoms. We will measure whether patients need the use of rescue medications, such as a nasal steroid or an antihistamine or eye drops, and that is the local antihistamine. And then we combine the use into one score system called the total daily combined score. And this is an example. If patients have no symptoms, they will score 0. If they have severe symptoms, they will score a 3. The medication is also scored, so we will have a maximum rhinitis score for medication based on desloratadine and mometasone. No, in this case, budesonide. Sometimes we're also using mometasone. Then the max score would be 12. So in that way, we have a balance between the symptom score and the medication score, giving you a total combined score of 24. When we look at the efficacy and the immunology, I want to share with you that the Timothy grass tablet have been evaluated across the world. So in North America, we're included in the trials. Almost 2,500 patients were evaluated in North America, and we had a similar size of trials in the European region. When we look at short ragweed, We had several adult studies, 2 adult studies conducted, and 1 pediatric trial. And they were carried out in North America, especially on the East Coast. So east of the Rockies, that's where we had the sites for the US. And then we included sites in Europe, including Hungary, Ukraine, and also we included Russia. When we look at the house dust mite, it's gone worldwide. So evaluated the patients both in North America, in Europe, and also in Japan. And then finally, the Treetopic has been evaluated actually in Russia, Europe, and we also had a trial in Canada. So we did a small trial up in Canada, and that's not reflected on this slide. The reason why I'm showing you this is because now we have data from across the world, and we have data from children and adults, and I think we have some interesting findings we can share with you at this meeting. So when we just look at the overall treatment effects, and this now based on this total combined score of medication use and symptoms. You can see for the Timothy grass, we have more or less the same treatment effect for the pediatric and the adults. There's a slight difference between 26 and 34% improvement. That was really because the trial was conducted, the GTO8 trial, so the adult trial was conducted in Europe, where we had a very strong pollen season. When we have very strong pollen season, we generate typically stronger treatment effects. So the more the patients are exposed, actually the better we see treatment effects. The pollen count in Europe at that trial during that year was around 120 grains per cubic meter air of grass pollen. For that same pediatric trial, it was only 28 grains per cubic meter air. So even though the exposure was fairly low, we still saw a quite nice effect in the pediatric segment as well. For ragweed in the adults, we actually had quite strong treatment effects, about 24, 26. We also now have a pediatric ragweed trial, which has been completed and actually granted an FDA approval last Friday. The treatment effect was better in the children than we saw in the 2 adult trials. House dust mite, we haven't really seen any difference yet between adults and children, but we still have ongoing pediatric house dust mite trials in North America and Europe. And then we had a birch trial where we had a mixed population. We saw similar treatment effects in adolescents and in the adults. When we look at the medication use, and this is just typically a reduction in nasal steroids and antihistamines, we see similar treatment effects for Timothy grass across adults and pediatric trials. Same for the ragweed, and we actually saw, and I haven't shown that on this slide, a quite high treatment effect in children of around 45% reduction in medication use. House dust mite, we saw similar treatment effects, and also for birch, where it was a mixed population of adults and adolescents. When we, from a clinical term, try to evaluate these percentages, it typically means that if patients need a nasal steroid, they will not need it if they're on active treatment. They can typically tolerate symptoms, either no symptoms, or they will be using an antihistamine. Those who are in need of an antihistamine typically will not need rescue medication. That's the clinical meaning of these percentages in improvement. When we look at the symptoms by itself, you can see overall similar treatment effects for the various species across the adult and pediatric groups. So when we just look in a summary for the entire study populations, where we look at Timothy grass, house dust mite, and birch, and then for the children, you can see overall we see similar treatment effects in the children. And basically, we have also shown similar immunological responses. So on the upper panels here on the left and right, you see the IgE response, and each color show different species, and the gray lines are the placebo effects based on IgE measurements. And you can see for house dust mite, grass, and ragweed studies, we see a steep increase in IgE shortly after the treatment initiation, reaching a plateau, and then we see a slight downregulation of IgE by time. For IgG4 on the right upper side, you can see IgG4 increases quickly also, typically within 8 to 12 weeks, reaching a plateau, and then the IgG4 levels are maintained during treatment. And we saw the same for birch, which is shown in the lower panel. So now I'll just pause and ask if there are any questions.
Yeah, can I ask you on the efficacy data that you showed? Some of the slides said compared to placebo, others didn't. So are those effects, the effect greater than the placebo when you showed reduction in symptoms?
Yeah.
Subtracted out placebo effect?
They all compared to placebo, and the placebo-treated patients all were allowed to use rescue medication. So it's not a true placebo group. Patients were using antihistamines and nasal steroids. So the treatment effect we see of the sublingual tablet is on top on the conventional pharmacotherapy.
Thank you for the talk. I thought it was excellent. I've used grass sublingual for quite a while and had, I would say, generally very good results. I've been pretty unimpressed with the change in looking at the data in dust mites, which in your presentation also was significantly less benefit, if you would, compared to the pollen. And while they are statistically significant, do you believe the ragweed, the dust mite data is clinically significant, a reduction in 16%?
That's a very important question, and I'd like to park it. I'm not yet finished with the presentation, and I'll try to address your question. And if I don't fully satisfy it, please speak up again, but I'll come back to it. But it's a very good and very important question, and I'll speak to it later if that's okay.
One other comment, when you showed that there were only 2 well-controlled studies of subcutaneous immunotherapy, what about all the work way back from Johns Hopkins showing the efficacy of ragweed injections? It looked to me like a lot of historical studies proving the efficacy of subcutaneous were omitted.
Yeah, in today's world, those studies would be considered pilot trials because they were a very small size. They typically were including maybe 20 to 40 patients. I'm very much familiar with Peter Krediker's work and also, what is his name?
Phil Norman.
Yeah, Phil Norman's work. And we actually used it to try to assess which dose we should aim for, because they actually measured the micrograms of major allergen. And in those trials, they typically use around 12 micrograms for subcutaneous maintenance injections and showed efficacy. It's true, those trials were quite convincing. In today's world, they would consider be too small to be able to substantially, to substantiate the effect. The FDA has new robustness criteria where they're looking at the 95% confidence interval, and they have set the criteria that in order to say it's clinically relevant, the treatment effect, it needs to be more than an antihistamine. On average, in pollen trials with antihistamines, you see treatment effects around 5 to 10% compared to a true placebo. And for the house dust mite, for the grasses, etc., the FDA is saying the treatment effect for at least 95% of the patients needs to be beyond 15 or 10% with a midpoint of 15%. And that's the reason why it's a fairly high hurdle. So you need large sample sizes to show what is the confidence interval around it. If you apply those kind of criteria to the older studies, none of them will meet the efficacy criteria as of today. But they were clearly, indicative of treatment effects. And I would say ragweed were probably the ones which were best studied.
Thank you for that answer. I didn't realize the size of the trial in retrospect.
Yeah. But I mean, it was that time where, we didn't have the same, setup, and we're not able, they were in single center studies, and that also affects the results and outcomes when you do multi-center trials across the world where you cannot control pollen exposure, the selection of patients, etc. Makes a huge difference. But it probably more mimics real world than just a small pilot in one center. Anyway, let's just share some data with the Treetopic. So the Treetopic trial was conducted with a placebo group and a active group. Total of around 600 patients were included. Patients were randomized in the fall, and the symptom and medication assessment was conducted during the alder hazel season and also during the birch and also oak season. So patients were typically on treatment for 12 to 16 weeks prior to the first season, being the alder hazel season. Primary endpoint was, as usual, the total combined score, and then we also had key secondary endpoints which evaluated the components of the total score, which is the symptoms by itself and the medication use. And we also evaluated whether the effect took place only in the birch season, which typically is fairly short, or whether there was a treatment effect across the entire tree season. And what you see here is that patients were typically 18 to 65, but there were adolescents included also in Poland. They all had moderate to severe allergic rhinitis, and they had to have a prior history of receiving symptom relieving medication, which did not give them full relief. And then patients were sensitized to IgE or sensitized to birch using IgE and skin prick test. And we measured the conventional symptoms, 2 eye symptoms and 4 nasal symptoms. And we assessed the use of antihistamines and nasal steroids. And that was all scored as I just explained. And now let me show the data. If you want to remember one slide from this presentation this morning, I would encourage you to remember this slide because it actually is a classical textbook example of how you demonstrate efficacy with immunotherapy. Along the y-axis, you have the pollen counts. So the lines show how the patients are having symptoms and how they're using medication across the periods where they have more and more higher pollen counts. And then along the y-axis, you can see the dates. So if you look at the start of the birch season, that's date 0. When you go prior to the birch season, you see the start of the alder and hazel season, starting typically around 40 days prior to the birch season. And then you move to the right, and you can see that the oak season typically pops up at the end of May into June and after the birch season. And then along the z-axis, that's where you have the total combined score. And what we see is, as symptoms increase due to increased pollen counts, there's a separation between active and placebo. Placebo shown in the brown line. If you're an active, you start having symptom improvement, medication improvement already during the start of the alder and birch season, or sorry, alder and hazel season. And you see a continued separation, more pronounced when you have high pollen counts during birch. And then you see the sustained treatment effect after the birch season. And you also then now see again a separation in the end of the season where oak comes up. Then you may ask, how come the symptoms are driving up at the end after the oak season? Because many of these patients also had a grass pollen allergy, and that's when they started having grass pollen allergy symptoms, which the Treetopic, of course, doesn't treat. And these are just the numbers. You can see for the total combined score, almost 40% reduction, 40%, close to 40% reduction for the symptoms, and 49% reduction in medication use. And this is for the entire tree pollen season. So that is including alder and hazel. And then we have the birch again. But let me just go to one more important slide, and that is really when we evaluated oak, because there's been a debate, can you treat tree allergies with the birch tablet? What about cross-reactivity? Well, most would probably agree that there's strong cross-reactivity to alder and hazel. But what about the cross-reactivity to oak? So we actually evaluated that in a chamber trial where patients were treated with the birch tablet and we exposed them to oak. And we saw a 24% reduction for birch and oak. We then also did the same for the assessment for the field trial. It was a post hoc analysis, but you can see we replicated the treatment effect from the chamber trial with 25% reduction. So for that reason, the indication in Europe includes the treatment of oak. So all the cross-reactive birch-related species are included in the label. In Canada, it includes alder and hazel and birch. All right, so that was the efficacy data. Let me just speak briefly around adverse events. So across the tablets, we see more or less class-related events. Most patients will experience oral pruritus and throat irritation, so fairly high frequencies, which typically last during the very first week or into second week of the treatment, and then it will fade away. Patients will become tolerant and they are not annoyed by the local side effects. More importantly, it's likely that most of the patients only have mild to moderate symptoms. Few patients will have severe adverse events. And if it is, then it's typically a severe pruritus. That is a nuisance and annoying, but not necessarily a safety concern. It would be of safety concerns if it was severe swellings, throat constriction, or even airway obstruction. And that happens or doesn't really happen. It's really, really rare. And if it does happen, it will be at the very first administration. But basically, you can see most of the allergen species will cause the same adverse events with some varying frequencies. It seems to indicate that the birch has slightly higher adverse event rates than the other tablets. And as I mentioned, about 95% or so of the adverse events are mild to moderate. Very few are severe, and they're typically manageable with an antihistamine. And when we look at epinephrine administrations, they're very rare. You can see that birch, there was nothing. For ragweed, there were a few. And for house dust mite, there was only one systemic. Basically, these adverse events, when they are systemic, are mild to moderate, occur on day one, and are easily manageable. If patients have an adverse event later, it's typically because they get nervous, they get scared because they have maybe a severe or concerning swelling in the throat, and they will take themselves to the emergency room and be treated with the epinephrine per SOP. We have very, very few patients who are self-administering epinephrine. It's a handful across 15 to 20,000 patients. So I will move on and then I'll ask questions, but now I'm coming to house dust mite. We did a house dust mite chamber trial because we were not sure how long it would take before house dust mite would kick in with efficacy, and we were not sure about the dose. We really didn't have any data to go back and look at what would be the right dose. From the chamber trial, we found that the optimal dose would be the 30 micrograms of the major allergens for the two species in total. We saw the treatment effect only with the highest dose of the 30 kicked in around 8 weeks. There was no early treatment effect of the lower doses. And then we saw a substantial progression in improvement up to 26 weeks with a 40% reduction in symptoms with the house dust mite in this controlled environment. We saw some effect of a lower dose, but it never reached the same. So what we learned from the chamber trial was immunotherapy is time and dose dependent. However, we don't see more treatment effect going on after 26 weeks. So typically you reach a plateau and you don't see accumulated effect of ineffective or low doses. The earlier treatment effect occurs only when you have the highest dose. Anyway, that was a 50% improvement in symptoms, so we were very happy with that. And now I get to the question around, well, what about house dust mite and 16, 17%? Well, the difficulty with house dust mite and those trials is that you're working in a very noisy environment. Patients have perennial symptoms. They often have other triggers of their symptoms, like changes in temperature, changes in in barometric, pressure or other triggers. So when you do a field trial, you have more noise. In this particular trial, which is a field trial with house dust mite, you can see the treatment effect kicks in around 14 weeks, and we have a sustained treatment effect throughout the year. Patients were initiated during the winter time, and that's when we started evaluating them. And then we did the actual efficacy assessment during the following winter season, where patients are indoors and more heavily exposed to house dust mite. But the interesting thing is we saw a sustained treatment effect in these patients who were also polysensitized. They had tree and grass pollen, and during the weeks between week 14 and 34, where patients were exposed to the environmental allergens, we also saw a treatment effect. So what does that mean? We don't know for sure, but we thought we'll take a closer look at it because polysensitization is common across the world. And that's one of the barriers, I think, for the use of sublingual tablets in the US, because the medical practice is based on treating patients' sensitivities. So if they are multiple sensitized, we treat with a compounded extract because we want to achieve the clinical benefit, and that seems very logical. On the other hand, tablets can only be used for monotherapy. So what's the benefit? That's the clinical question. And it is an issue across the world. Patients are polysensitized, and in the clinical trials we ran, 75% of the patients were polysensitized. And you can see we just took a look and say, okay, if you are polysensitized, would you be maybe less responsive to the treatment for that particular allergen? When we look at house dust mite, grass, and ragweed, we really didn't see a difference for the treatment effect of house dust mite or the treatment effect of grass or ragweed, that there was a difference if you were polysensitized. But that's not good enough. The clinical question is, well, if patients have another allergy, what's the effect? Could there be a bystander effect or something else? 10 years ago, if you had asked me, I would say polysensitization might be treated because there could be a potential bystander effect if you skew the immune system towards a Th1 response with immunotherapy. We did a trial to assess that, where we evaluated patients who were treated with grass tablet and exposed them in the chamber to birch to see if there was a bystander effect on the birch exposure. Absolutely no effect. So if you ask me today, do I believe in bystander effect for immunotherapy in adults? I would say no. If you ask me about maybe in children and infancy, I would say that's possible. We have data suggesting if you treat very early on with house dust mite in infancy, you can get a bystander effect on other allergens, and that's something we want to confirm now. But in adults, I'm skeptical. But it brings me to the next question. Could you see a benefit in these polysensitized patients? And that's what you see in this slide. It's a little bit complicated, so let me explain it to you. In the left, we have house dust mite monosensitized patients, and they had no grass or tree sensitization. And you can see, we see a fairly nice separation between active and placebo. One, don't really see any real change until maybe in October when they are more indoor. You turn on the heat and patients starting having a little bit of symptom when you look at the placebo group. So that's the gray line. On the right side, on the other hand, you have the total combined score for those who are house dust mite sensitized and also had a grass and tree sensitization. Here you would expect that the placebo-treated patients and perhaps also the house dust mite treated patients should show an increase during May, June, July when they're exposed to tree pollens and grasses. Maybe the placebo group has a slight increase, but it's not that clear. However, remember these patients in these trials were allowed to use rescue medication, and they were encouraged to use rescue medication. If they had a daily score of more than 4, they would be prompted to start using antihistamines, and if that did not control the symptoms, add on the steroid. So for that reason, these patients were probably using rescue medication during the year. So maybe we should take a closer look at the medication use. And that's what you show in the next slide. If you focus on the right, that's where you have your polysensitized patients. Placebo-treated patients started using more rescue medication during the pollen season compared to the house dust mite, suggesting that these patients who were on active treatment had some clinical benefit even during the pollen season. And now the question is, how could that be? For those of you who have learned about priming, that was something I learned when I was in my fellowship program. Priming could be a potential reason. If you are primed to house dust mite during the winter season, and then you come into the tree pollen season, you have a higher inflammatory response in the nose or in the nasal mucosa, and therefore less pollen can actually trigger an allergic reaction because the patients were primed during winter season to house dust mite. If you take the priming effect away by treating with house dust mite, these patients may not be easily triggered by the pollens, and therefore overall they will maybe have a dampened response to the pollens. So it could be a priming effect. I'm speculating, but I think that is a possibility. The other possibility is that we have underestimated the presence of house dust mite during the pollen seasons. So if you treat the underlying house dust mite allergy, you are reducing the overall burden of disease by taking out the component of house dust mite. And maybe therefore they would be less affected by the allergies during the pollen season. I don't know what is the true answer here. We are now studying this prospectively, and we'll try to come up with an answer. But those are possible explanations and why patients actually may benefit from monotherapy. And now just briefly on the question about 16%, I would say in the controlled environment, which is probably the optimal assessment of the drug efficacy, we did see a 50% reduction in rhinitis symptoms. And I think that is actually quite significant. When we look at perennial allergies in general from pharmacotherapy, the treatment effect is less. So when we look at antihistamines, and I had access to that because I used to work for Sharing, I also had access to singular data. In the perennial trials, the treatment effect is typically around 5% for the antihistamine and around 11% for mometasone. And for singular, it was between 5 and 8%. Against a true placebo. For the house dust mite, you see the treatment around 16 to 17% on top of the rescue medication. So I think that indicates that there's a clinical meaningful treatment effect, and so was the decision by the FDA. But that's the best way I can respond to it. And also, by the way, it's very difficult to compare the older trials with the newer house dust mite immunotherapy trials, but that's the quickest explanation I can give you. And let me then pause and ask if that satisfied your question and if there are other questions. And then I'm actually about to close my presentation for today.
I have a question. Mike, I don't know if that satisfies your question from earlier, but
Sure.
the question I have, you would think that if you offered people a way of self-treating at home compared to coming in for injections, this would be a very successful treatment. And yet I recall data that if you follow actually the adherence that people have to this form of therapy after a 1 year or so, that it's, in my estimation, very poor. Like 20% of people stick with this kind of treatment. Is that correct? Do you know, in real world? And other than just being human nature, if that's the way humans are, isn't that very disappointing?
It's a very complicated question, and let me try to see if I can be clear in my answer. First, let's set the right expectations for adherence. When we ran the asthma trials, and later on when I evaluated Asthmanex and steroids, we knew from our real world experience that patients who even have had asthma exacerbations were typically 50% adherence to their inhaled steroids throughout the year. The average canister prescription rate typically ranged around 4 or 5 per year. When I looked at the cholesterol franchise and with patients who have had acute myocardial infarction, the adherence rate was around 50. And when you look at, for instance, tamoxifen or anti-estrogen, the adherence rate is 70 to 80%. So that's the problem we have with all drugs. Then the other complication is reimbursement. In certain countries, we have full reimbursement. So for instance, in Japan, the children don't pay at all for sublingual tablets. There we have adherence rates for 3 years, 80%. In the Scandinavian countries where you have full reimbursement also, over a 3-year perennial treatment period in real world, we have 85% adherence rates. If you go to countries like the US where people have variable insurance coverage and where they may have high deductible plans, it can drop down to 25 to 50%, depending on the plan, etc. Also, socioeconomic factors plays a role. So I think it depends very much on a number of measures. When we look at SCIT, we know that after 3 months, 30 to 50% of the patients have dropped out. So of those who are initiating SCIT, 30 to 50% dropped out. Those you see in the clinic who continue to have treatment are the enriched patient population where they are committed to do the SCIT therapy. So it's really important to look at all initiations versus those who stick to the treatment in the clinic. So I would say it depends on multiple factors: high deductible plans, reimbursement, how well you inform the patient, if you have frequent visits. So if you see patients every 3 to 6 months for follow-up, they have higher adherence rates. When you only see them once a year, clearly it drops down to 25%. So it's a complex question.
Hi, this is Paul McBride. Do you have any thoughts of whether the Birch oral immunotherapy is going to come to the United States?
So we are right now in dialogue with the FDA about the development plan. We have, approval, as you heard, in Europe and Canada. We're trying to see if we can make use of that. We have an ongoing pediatric trial now with the Birch tablet or tree tablet for Europe and Canada. And we're trying to see if also the FDA would agree that we could run sites in the US with that trial. So we are in a dialogue.
What would you say? I know a number of people have tried to do head-to-head or comparative studies on the comparative efficacy of SCIT and SLIT. And I think a lot of American allergists, maybe because we're biased one way, have the general impression that cutaneous immunotherapy is somewhat more effective overall. Is that correct? Or is there no way to do a head-to-head comparison properly?
It's very difficult to do a head-to-head study, but it can certainly be done, and it would be a fairly large trial. But I would step back for a minute and say, should it be either or? I really don't think so. I mean, I used to practice, and I use patients who are really good candidates for injection therapy and did that. And then there are patients who had a different preference or other needs, and for that reason, I would use sublingual. So I think both treatment modalities should really be available to the physicians. Having said that, there's actually one good trial, although it was small. It was a very well conducted trial by Moises Calderon and Stephen Durham, where they evaluated the Timothy grass tablet, which had the same formulation as the injection Timothy grass extract they used. The study showed that you need to treat for at least 2 years, and therefore preferably 3 years with sublingual tablet to have sustained treatment effect. But there was no difference in the clinical outcomes, which was based on nasal provocation between SCIT and SLIT after the first year. So that trial didn't indicate, and you'll hear Stephen Durham say that there were no indication that one was stronger of efficacy than the other. And that's the only trial we have which is head-to-head, done in, I would say, in a proper manner.
We have other questions there. It's I think it's just about 8 o'clock.
Is there a word of the day?
Yes. Here it is.
There.
That was the best question.
Therapy.
So,
All right, thank you very much.
Slideshow, what do we have in the US? 15% uptake of SLIT as a
Yeah, I would say it's around 15. It's actually increasing. There's quite a nice growth over the last couple of years. I think compared to last year, the growth is about 50-60%. I think COVID has a lot to do with it, and that makes sense. I would say, I mean, if you ask my personal opinion, one of the biggest reasons for why there's not better uptake is really the medical practice is very different from the rest of the world, treating all sensitizations. And some would believe there might be a financial incentive.
I had two questions. Can you hear me?
Yeah.
Yeah. So, one is with the birch, treatment, is there, or, or even with the grass, in terms of, esophagitis or, the food cross reactivity that we tend to see in other patients, what's been the, association that's noted with treatment, with birch pollen, or, especially how many of them have been tracked or known to have, either GI symptoms or esophageal symptoms? And second is just a comment, or just a, unrelated, is the background noise that you were referring to with the dust mite treatment with the non-allergic factors. But I don't think non-allergic factors are unique to dust mite. They're probably also seen with, people who don't have allergies, or certainly or even with pollen allergies. So, how's that, so I'm trying to make sure that non-allergic factor is not just a dust mite problem, but also a seasonal problem.
Yeah, so let me go back to the very first question. I mean, it's really interesting. Could, for instance, the birch tablet treat oral allergy syndrome? And we actually did an exploratory analysis. We had 120 patients in the adult trial where we actually did apple challenges to those who had oral allergy syndrome. And we did see that the patients had diminished symptoms and actually tolerated higher doses of apple before they started reacting. So the pilot data indicates that there could be a treatment effect on apple. We need to confirm that in a dedicated trial, but it was encouraging. When we look at the side effects, clearly we are concerned that EOE could, be a potential effect. And it actually originates from the peanut desensitization trials, where the FDA picked up the signal that with all allergy treatment, you can have a risk of eosinophilic esophagitis. So we are monitoring it as a safety signal. We have not confirmed that. The background rate in the population is higher than what we have seen in pharmacovigilance. But it's not a validated signal, but it's a safety signal we are monitoring. I'm postulating that the risk might not be so high with the Vitis technology, which we're using, where we have this rapid uptake in the sublingual space, because the patients really don't swallow the material, doesn't get into the lower gastrointestinal tract, and therefore I think the risk is less. I think there's potential unmasking. Some of the cases we have had a few, I mean, across all the tablets, I think we have had around 5 cases of EOE, which were more or less confirmed. But the strange thing was that typically would occur within 1 or 2 months of the treatment. And typically, as you know, EOE is a more chronic disease, where some of the findings based on my review suggest that maybe it was really an unmasking of an underlying. Many of the cases have not been treated with a PPI, so I also think reflux may have played a role causing eosinophilia. But those are my opinions. Right now we're monitoring it, but I don't think we have a validated or confirmed signal. Coming back to the background noise, I tell you, it's really hard to run these house dust mite trials. First of all, identifying a true house dust mite allergic individual is difficult. We have high screen failure rates because patients think they are house dust mite allergic, physicians think it, and we cannot confirm it with the presence of IgE. And even then, what is really dominating the symptom complex? Is it the house dust mite or is it something else? I don't think we have a good way of figuring that out. And that's the reason why I have a preference for using the chamber trials, because they are in some way better controlled. And I think we can see at least the best possible treatment effect in a chamber trial. If you don't see a strong treatment effect in a chamber trial, I would question the value of the drug. But we have seen that. But it's difficult in the clinical trials to show the efficacy, because in the other trials we have more narrow seasons. It's easier to diagnose the patients to, for instance, birch or grass. So I think the quality of the patients we get into the trials are probably better than we have seen in the house dust mite trials. But those are just my considerations.
Dr. Nolte, thank you very much. I know a number of people need to move on to other things out here. It's 8 o'clock on the West Coast. Thanks for an excellent presentation. I think for American allergists, sort of eye-opening as to how we differ from the rest of the world.
Thank you very much. And thank you very much for the invite.
All right, bye-bye.
Bye.